Call the open session of the Tahoe Forest Hospital District Board. I want to welcome all of you to our open session. We have some deletions or corrections to our agenda in the open session of the Tahoe Forest Hospital District Board. I want to welcome all of you to our open session. Okay, we're just gonna move on. Deletions or corrections to our posted agenda. We did have one deletion that we deferred until next month, and that's under the consent calendar. Item 13, it's 13.3.5. Any other deletions or corrections that need to be made to the agenda? If not, then we will move on to audience input. And this is an opportunity for the public to speak to the board and give your comments. You have 3 minutes, and know that the board cannot respond if it's not agendized, but we certainly can take what you say into consideration and pass it on to staff to work on or agendize it later. So do I have any audience input? This full audience and I have no input. No. Okay, then I'm going to move on to the input from our Employees Association. Okay, and they're absent today. Then we'll move on to 12, the Medical Staff Executive Committee, and this is Dr. Joy Koch.
So Dr. Joy Koch here for the Chief of Staff report, consent agenda. And we have 3 items under the consent agenda today. The first of these items is creating a policy or procedure for administration of ibuprofen or acetaminophen for fever in pediatric patients in the clinic setting. Currently, there is a policy that is very similar to this in the emergency room setting. It allows an RN to provide fever relief for a patient showing up in the clinic. That's policy number 1. The second policy that requires approval is a standardization for vaccine screening and administration. Currently, there is one procedure document, and then there is a separate policy document, and they have been put together into one document so that it's a little simpler. There were no other changes with that. And then the third is some updates to the management of disruptive behavior from patients or visitors. They expanded the recommendations at each level of disruption to include, for example, contacting the police or contacting security and considering an ethics consult. So they just expanded the policy a bit. Any questions on any of these?
I'll move to approve the Medical Executive Committee consent agenda as presented.
Okay, could I just ask the audience first if they had any comments or nothing from staff? Okay, then we have a motion on the table to approve the MEC's consent agenda. All in favor?
Aye.
Opposed? The consent agenda has been approved. It was a mistake on my part. We didn't have the report from action taken in the closed session, and we have Mackenzie Anderson, our legal counsel, on Zoom. Okay, we can't hear you.
Oops.
He's saying something.
Still can?
Yep, there you go.
Yep, there you go.
Great. Okay. Thanks. So first, the board held a hearing pursuant to Health and Safety Code Section 3215 to consider the third quarter corporate compliance report, which the board approved unanimously as presented. Next, the board held a hearing pursuant to Health and Safety Code Section 3215 to consider the first quarter fiscal year 2025 quality report, which the board also approved unanimously as presented. The board then reviewed the closed session minutes for the meeting held on October 24th, 2024, and approved the minutes as presented. And last, the board held a hearing pursuant to Health and Safety Code Section 3215 to review medical staff credential recommendations, which the board approved as presented. Thank you.
Thank you. Our next item on the agenda is our consent calendar, and these are generally reports or non-controversial documents, but the board has the ability to pull anything that they would like to have further described or discussed. Anything from the board on the consent calendar?
Nothing for me.
Anything from our staff that they'd like to have pulled? Any comments on the calendar from our audience? Can I have a motion to approve the consent calendar as presented?
So moved, Dale.
A second, please.
I'll second.
All in favor?
Aye.
All opposed? Then we'll move right along to items for the board's discussion. Our first item is the Tahoe Truckee Workforce Housing Agency, and we have Heidi.
Jacqueline.
Okay, I was just going to ask if,
Program manager,
and Jacqueline is the program director.
Manager,
Man-
yes, thank you.
So welcome, ladies.
It's on, yes? Great, thank you. Thank you for having us. I'm Heidi Alstead, Truckee Tahoe Workforce Housing Agency. Nice to see everybody. Thanks for having us. Oh, can't see. Just this? Sorry.
This little button there.
Oh, got it. Okay, so great. So thanks for having us. So our mission is to facilitate workforce housing solutions in the Truckee Tahoe region. We are part of 7 member agencies, and the hospital is one of our top member agencies. We were founded in 2020 to provide housing affordability for the 2,300 employees of our 7 member agencies. We expanded in 2023 to serve the housing needs of our greater workforce. Since 2020, we've served over 600 people with housing services. Just to give you kind of a quick timeline, we were created out of the Mountain Housing Council discussions back in 2018, and our agency was founded in 2020. We decided to look at our member agencies, which are public agencies, looking at their land to see if there's any opportunities there to provide development. So we conducted an exercise. Through that, we identified 2 sites that we were looking at developing. We're working on those now, and I'll get into those in a minute. But in 2021, we expanded our member agency to include additional members, and then we launched some services in 2022, and then in 2023, our new strategic direction was approved. Currently, we have 7 board members. We have 14 in total, but there's an alternate for each agency, and then 2 staff, myself and Jacqueline. And Louis and Ted are on our board for the hospital team. Just want to give you kind of a quick background. It's probably been a while since we've been here. So we do accept fees, membership fees from our 7 member agencies to run our organization. And the hospital district is the largest member agency to date. We really look at the Mountain Housing Council's updated housing needs assessment that they completed in 2023. We're still looking at almost 8,200 total housing needs in our community in the North Tahoe and Truckee region. The most unmet housing needs are the 80 to 120% area median income. Our focus, however, is on the 80 to 245% area median income. This is a group that doesn't really have a lot of services or support around housing, so we were here to help with what we call the missing middle. So the way that we do our work is that we connect people to local and statewide housing resources, local rental programs. We have 2 down payment assistance programs. One is with the hospital, which Jacqueline will get into more in detail here shortly, and then a housing concierge support, and then a rental housing match program. And then we just launched a new master lease pilot program. We're working with a local developer on a 9-unit apartment complex, and we're able to help him rent those units out pretty quickly, and we're moving into a master lease process in the next couple months. So some of the benefits, you think, housing, it can be stressful if you don't have a place to live when you move to our community. And so we really feel that we've heard from the community, from member agency employees, that they feel supported in accessing our housing concierge services. They also have some satisfaction and well-being at their job because they're able to find housing. And then also it really helps improve recruitment and retention, which we've seen a significant number of successes through the hospital employees and recruitment process. And then also the community engagement around housing as well. This is a lot to look at, but what I will focus on here is, these are our stats from last year for all of our member agencies, but what I want to focus on is that since we've created the agency, we've served over 205 employees of the hospital with housing services, and this past year we've served over 72 people with housing services. And 5 of those accessed our home purchase program, which you've funded so graciously, and so it's been a very successful program. Programs. Jacqueline McCoy is our program manager. She'll go through the programs.
I'm Jacqueline McCoy. Thank you for having me here. I want to thank you guys for supporting this agency. I don't know any other region or anywhere else that has an agency like this, so it's an honor to serve in this capacity. I'm going to go through the different programs that we have within the agency. The first one is the concierge services. So any of your employees and anyone in the Truckee Tahoe area has access to our services now. As Heidi was saying, in 2023, we expanded to serve everyone, not just the 2,300 employees that we originally were serving. So if you need a rental, you can email me, call me, and we will try our hardest to provide rentals for you. One of my roles is to advocate for affordable rentals. So I have a lot of conversations with homeowners in the area, and I try to educate them on the market, the softening of the market, and try to bargain with them. We do incentivize them with your financial dollars that you guys contribute within our home match program. So we say, if you lease to one of our employees for this rate, you can qualify for this program in addition to the town's program, Lease to Locals program. So we have had great success in our rental program. We also, our concierge services also help people and promote people to purchase a home if that's your goal. So we educate on the original programs in the area, and we also educate on your guys' program in the area, the employer-based down payment assistance program. The home match program, the stats over the fiscal year 2023 and 2024 is that we've connected with 200 of your employees. We tallied, I have a database that marks all of my activities. So half of our services are for your guys' employees. Last year, we served 72 hospital employees, placed 3 families in rentals, and then within the first quarter of this fiscal year, we assisted another 3 families or 3 employees by connecting them to different rentals. Thank you, Heidi. So you guys pioneered the Home Purchase Assistance Program, which is an employer-based home purchase assistance program. It serves as a down payment for people trying to buy in this area. It's 16% of the purchase price at a 3% simple interest loan. What makes this different from the local other down payment assistance programs is that it doesn't have a AMI cap. So a lot of the local programs, if you make more than a certain amount of money, then you're not able to access those funds. This one within the hospital, there is no cap on that. And so the reason that we made that is because HR was trying to recruit some talent that made above that, and they weren't able to move here because they weren't able to afford either rentals or for purchase products. So, no, you can stay there. Sorry. So our yearly budget that you guys have graciously approved is $900,000 per year. So far to date, we've processed 10 loans, and that we've distributed almost $1.5 more than $1.5 million. Thank you, Heidi. Yeah. So this is a spreadsheet that I work with. The first column shows the number of loans, 10 loans. It's broken down by fiscal year. So you can see in the first year, which we only operated for 6 months, we processed 2 loans and 6 loans, and then now we're at 2 loans. This program was originally for,
Sorry, I'm going to skip that slide.
go
Okay,
ahead.
keep talking.
This is this is just one example of, you guys can read it on your own, of someone who provided a testimonial on our program. So it's highly, highly successful. I want to say that HR works closely with us. So when they are trying to hire talent here, they will tell them about our concierge services, and they will also inform them that after a period of working here, they'll have access to the down payment assistance program.
Great. So moving forward, our fiscal year started July 1, and like I said, we launched a 5-year strategic plan in 2023, and we looked at these goals and strategies this early spring to look at, just to sort of see where we were with our strategic plan. So moving forward, we're looking at creating innovative financial tools. So we're looking at fund management agreements between our public agencies to help fund some of our development projects, as well as regional housing programs. We are also implementing a fundraising plan as well, and to really create those dollars to get some projects off the ground. Now, number 2, we are working with, like I said, we were identifying sites to develop, and we've identified the TTUSD Alder Creek site and the U.S. Forest Service Hobart Mills sites as our 2 potential development sites for 24-25. And we're moving forward with TTUSD. We've hired employee housing partners out of the Bay Area to do a feasibility analysis, as well as some engineers to look at the site, hopefully before the snow flies. And we've also, it's come to our attention that the Hobart Mills site is not moving forward. It was fairly complicated with the Farm Bill this year, so that is not moving forward now. But we are focusing our efforts on development on the Alder Creek site. So we are also looking at acquisition as also part of our strategic plan. We decided to put that on hold for this time because of the development work that we were doing. And so we're still, we want to remain nimble, we want to remain flexible, so we'll continue to talk about acquisition as we move forward. We're also looking to expand some of our programs, and we're speaking with Placer County right now to administer their workforce housing preservation program and their lease to locals program. So we're really working on that so that it gives their staff time to free up for other housing activities as their housing programs grow. And then also, like I said, we're launching a master lease pilot program, which should launch here in the next couple months with a local developer who we're also working with on other potential sites as well. He's been a great partner. And then another exciting opportunity is that we are working with Sierra Business Council around launching a public affairs housing advocacy program. It's just really a continuation of the Mountain Housing Council program. This is an ongoing effort. This isn't a one and done. But what we're doing is we are working with our partner agencies, our entitlement agencies, and their legal or their legislative folks around state housing legislation. So this will be really important to our region. So moving forward, that project is kicking off at the end of this year, throughout next year, and so we'll keep the hospital updated on those activities, but we're excited to get that off the ground. That's all. So thank you so much for having us. I can answer questions if there's time or.
Curious, you mentioned that there's a shortage of roughly 8,000 housing units. How does that information get gathered?
Yeah, so the Mountain Housing Council worked with BAE to create a regional housing plan. So they are collecting data from all sorts of places to look at the needs in our community. There's quite a bit of housing here. It's just, either short-term rental or it's second homeowners, right? So there's housing, just being able to access that is not, so we're working with people around incentives on accessing their homes, so.
They did that through
Yeah.
surveying, and we're
Yeah.
going to have another survey. We're going to collaborate with them in the springtime to perform another survey to
Yeah.
get more up-to-date
So I see it's a
numbers.
sample survey and then they extrapolate it.
Yeah, they'll use survey data, but they'll also get census data and that kind of thing too, for the regional housing plan update. Yeah.
Heidi, could
Yeah.
you go back to the previous slide
Yeah.
here, please?
This one?
Yes, under the facilitation of development of
Yeah.
workforce housing. You have in the second bullet, you have determine what the role of JPA is going to be in development. Obviously, it's to be determined, but what is the leaning on that right now?
Yeah, that was something that came up during earlier in the year around our next steps with our strategic plan, and we were really kind of wondering, what is our role? Because we're morphing, we're changing as new projects come up, and so we really want to be able to answer, what is our role? We're not developers, and there's 2 staff. So, one of the ways that we can really serve in that role is facilitation around, a lot of developers will call us and reach out to us. We educate them on what the need is and how many employees we're serving. And we work with all the other different housing agencies. So we're a great educational resource for them as well. So we're talking about that right now. Actually, at our next board meeting, we'll be discussing more in detail, brainstorming around development. What does that mean for us?
Would it be possible to get us copies of your slide deck?
Absolutely.
It was really hard to absorb all that.
Totally, yeah,
information
yes.
As it kind of went flying
Sure.
by, but-
Yeah.
So, yeah, I mean,
Yeah.
if we could get a copy of this.
Oh, for sure, absolutely, yes, anytime. And we're also working on quarterly reports as well, so we can provide that to Louis and to Ted for any questions you may have, and happy to come anytime and answer questions as well.
I have a question for you. How much available developable land is there for workforce housing? I mean, I would think it's kind of a scarce resource.
Developable land, there's not a lot. There are projects that are in the works. Getting them entitled is difficult, can be difficult, and financing is very difficult for projects. The lower income housing projects, there's state funding and federal funding for those. For workforce, it's a little bit different, and so the gap is very large. And we're finding right now that it's around $1 million a door to build units. So it's very pricey in our region. So we're looking at all sorts of alternatives and looking at, creativity around modular units. A lot of the complexes in Truckee have used modular. So we're looking at what's the best cost benefit for that, but it's very pricey. It's very complicated.
On
Yeah.
that topic, I look at these innovations in design, and one of them was a company, I think it's either in Japan or Finland, and they produce what look like finished kind of trailers, and for a fairly reasonable price. They're all insulated, they're designed for use in, difficult spots so you can put a foundation under them. So I wonder if some of that type of innovative housing might be something that you look at.
Heidi mentioned the pilot program, the master lease pilot program that we're partnering with the developer. So his 9 apartment building is modular. So he has made it pencil to where rates, we were able to offer below market rates because it was a modular structure. So, so we are partnering with
Yeah.
him since he's made it happen so far.
Yeah.
And we're looking at all sorts of alternatives,
Yeah.
building alternatives, yeah.
As far as the Alder Creek property, what kind of housing are you thinking about developing on that? Multiple units?
Yeah.
Or single dwelling?
It would be mostly apartments because it's a small site. And so we're working right now with obtaining an architecture firm. We're going to be making some decisions on that over the next couple weeks. So hopefully we'll have a site plan designated in the next couple months, and we can share that with the community as well. So we're not entirely sure yet till we see the concept design.
Are people looking for any kind of housing they can get, or are they being particular, like, I really want a single-family home, I've got children, I want,
So when we've surveyed your guys' employees, they all want single-family homes, of course, right? We all do, but then there's the townhomes, and then there's the multiplex complexes. So yeah, single-family homes are desired the most, but we know that other people do buy townhomes as well, so.
I just mentioned that because just on my street, I've noticed 3 houses that are up for sale. And so I go, I wonder if workforce housing knows about these. Not that you're in the business of real estate, but you want to keep your eye open for what's available so that as you have people come to, talk to you about it, that you say, well, there's homes in Glenshire and there's homes in Tahoe, Donner.
Absolutely.
Thank you.
When you work with one of these agencies to develop workforce housing, and for example, if it's on TTUSD land, I would imagine they are probably donating the land.
Correct.
Yeah.
You will be developing that land. Do the TTUSD employees have priority?
Since they're part of our, 7-member agency, so it's not, because of the financing, it's very expensive. The school district doesn't have the funds to house just their employees. So we're really opening it up to our 7-member agencies to see, they can all access. So we'll be looking at the needs of all the employees for that particular site.
We haven't set up program parameters, but I think that because they are donating the land, there will be some preference, but it will be mixed use. Yes, absolutely.
Yeah, absolutely. No,
And there are
absolutely.
benefits of developing in school district land. So that's why we're going, we chose primarily this land because it is school district land. So we have specific lawyers that know the loops behind that. Yeah.
There's a lot of finance, there's some financing available for
Yes.
school district
Okay.
workforce housing.
Any other questions from our board? Any questions from our staff or audience? Any of you need housing?
Give us a call.
I just want to say that HR does such a good job of connecting us with new hires. So whenever there is a potential new hire, if they have an offer going to them, they connect them with me, and then I either, whether their housing goals are for rent or for purchase, it's really nice to be able to support them in their hiring needs as well. So they're doing such a great job.
Yeah.
Well, thank you. Thank you for the work
Yeah.
that you do to help us attract our employees
Yeah.
with housing.
Thank you for
the
all that you
support.
do as
Yes.
well for your employees. Yeah, it's great.
All right, thank you.
Thank you.
We'll see you probably in several more months.
Right?
Okay, our next agenda item is the Vizient project, and we have Jeff Wilson and I think Kelly Downs to talk to us about the update.
Okay, and then just,
It's just this little button right here. Just remove it. Slides.
perfect,
And you got 5 minutes to do it all.
perfect. We'll be quick.
How much? Kidding. I reviewed their slide deck yesterday. I said you have 5 minutes to do this. There's no way that's happening. There's a joke. Seven.
Well, it's good to see you again, Jeff.
Thank you very much. Good to be here. A couple of folks stepped out. Should I wait till they return, or are we on a break, or do we start now?
No, they're gone. Some of them are left.
Okay, all right, good. Okay, well, good evening, everybody. Thank you so much for having us. Appreciate the opportunity to connect and give you an update. I guess, to be formal, I should announce my name, Jeff Wilson with Vizient Incorporated. Been working with the Tahoe Forest System now for just a little over a year, approaching a year and a half. So happy to be able to be here tonight and give you us an update on some of the things that we've been doing and will be doing. One of the primary deliverables of our relationship with Tahoe Forest is to help build the internal capacity to do the kind of work that we're doing together, so that eventually Vizient kind of fades into the background or takes on other roles, and you guys have the capacity and capability to continue to push this work forward. And so tonight I feel really blessed to be here with my partner in that endeavor, Kelly Downs. Kelly's going to share with you an update that reflects a lot of the work that she's done and we've done together. And there's really, I think, several success stories here that you're going to be interested in. And so I'll just turn it over to Kelly, I guess, and we'll get into it.
All right, thank you for having me. Kelly Downs. Technically, my title is change manager, but for the last year and a half, I've really been focused on process improvement. We're really excited to give you some of the updates on the good work we've done. So if we start out, we just wanted to give you kind of an overview of the numbers that we're looking at. We've had 5 departments in our first cohort. We've trained over 30 people. The reason why it's 30 plus is because we've had several people who have kind of come in and out of those different areas. We have had 5 after today, rapid improvement events where we focused on individual problems, and we've had 23 plus processes that we've developed and deployed standard work. Standard work is really just defining the process and making sure that everyone's following it. We have focused on our 5 departments doing visual management, which means that we are offering statistics and really telling the story of all the process improvements they're doing. We've had 22 plus people who are currently doing leader standard work. Leader standard work is really around coaching and directly observing the work that's happening. So we really focus on that sustainability piece. And we've had 25 plus people working on projects or problems outside of directly the problems that we focused on during our rapid improvement events. So we're really excited that we're expanding this work and really moving beyond just what we've done directly with those groups. So one of the things that we're really excited about is developing a model area assessment. And this assessment is focused on our 4 main areas around management systems. So we focus on standard work, that's standardizing our processes, leader standard work, which is really focused on coaching and observations to make sure things are happening. It's about sustainability. Focused problem solving and really focusing on the data that we can use to leverage that. And then the visual management piece, which is really telling the story through pictures and charts and data. When we look at this, this was what we gathered in September, so we are continuing to do it. But the reason we really wanted to create this assessment is, 1, to develop what competencies are around each of those 4 areas, to really provide the expectations for those departments that are working with it, and then be able to actually see where people are and create detailed action plans. So in January, the expectation is that all of our 5 current cohort in cohort 1 will be completed, so everyone will reach 100% on all 4 areas. And then from there, we'll move on to our cohort 2 and really focus on bringing the next round of people together. One of the things that we're really proud of and really excited about is that we've found that this process really works. So, which is really exciting. Yep.
Surprise.
And I wanted to just share an example of that we have seen. So previously, or recently, we had a provider come to us and say, we have all these no-shows, we don't know what's going on, why are people canceling their appointments? And so we looked at the data, or actually in the old way, we would have just jumped on it. We would have put up signs, we would have sent out letters, we would have just gone and done a bunch of things. And really, most of the time we had leaders individually making decisions around what those things should be. And we really wasted a lot of time and resources to not actually fix the problem. In the new way, we went and gathered data, and we looked at what our no-show rates were for that particular department, and we found that it was about 4 or 5%. The national average is 18. So when we looked into the data, we found that maybe this isn't our biggest priority, maybe it isn't our biggest problem. And we were able to build the alignment with not only the leadership team, but also those providers to say, maybe this isn't what we focus on. So we're really excited that we looked at the data to decide which problems we were going to solve. We were able to get down to the root cause. And we really felt like we were solving for the right problems rather than jumping to solutions that may not help. So now I wanted to give you a little bit of an update on our Access to Care project. And I know you guys have heard a lot about this. I'm excited to give you some good news and some future improvements, opportunities. Yes.
Good news to come later.
We do have some good news, though. So if we look over the last year, we did quite a few things in the clinics and with our diagnostic imaging. All of these also impact our access centers, so we saw improvements in a number of different areas. I'm not going to read through them. These are kind of the small ones because I want to focus on our big picture pieces that we're working on now. So before we get into that, the piece that we are really focused on now is around provider templates. And I wanted to just be able to give you a little bit of background on why this is so important. So on the left side, you'll see a copy of the provider template. This is really the foundation of how we schedule our patients. In our current state, or at least when we first started this project, they were incredibly complicated. They would have blocks for different things. It would be very hard to get patients in when they needed to. Some providers would have specific holds for different things. If you look at the top, there's a whole section for an hour where that's blocked off just for clinic access, which means the access center isn't able to do patients. And so each of these little blocks is really, it's a place where we can put patients. The blue ones are actually patients that are in there, but for HIPAA reasons, I blocked them out. But just I wanted you to be able to see the difference between where we have holes, like where you have opportunity to actually put a patient in and where you don't. And the reason that we really focused on the templates is, thank you. We did an event today and I spoke all day and now I'm losing my voice.
I know that feeling.
We'll tell you a little bit more about that later. So the reason we were focusing on the templates is because we felt like that was the place where we needed to start with our foundation. It's the foundation of how we get our patients in, but it's also how we can increase access. We're really working on standardizing so that all our providers have the same types of access rather than having some who have more and less. It also allows us to use Epic functionality to really put guardrails around how we schedule, and it allows us to really create the templates that we want them to be in. It makes it so much easier for the access center to be able to schedule because those guardrails and because there are standard definitions around what should go in them. And one of the biggest pieces, and I know Louis is really excited about, is allows us to look at future functionality in Epic. So things like online scheduling, FastPass, which would allow people to move off the wait list quicker. All of these different things, Epic functionality is available, but we can't do it now because our templates are so crazy and chaotic. One of the biggest things that I'm excited about is that it will really allow us to look at our reporting accuracy better. So this is our third next available. I know you guys have heard a lot about this, and you've probably seen some different numbers over time. One of the things that improving our templates will do is actually allows us to see a more accurate picture of what that third next available is. By creating the templates correctly, it's going to read the templates correctly. So rather than saying a block isn't available, it will actually show that it is. And so I'm really excited to show you the next slide, because in the Women's Center, we have done a lot of work around their templates. It's both standardizing their visit types, it's looking at how we build them, it's building in some of those Epic guardrails, and we're seeing now that we've made some improvement in access based on what we've done to the templates, but we also now see a more accurate picture of what that actually is. So if you're looking at this timeline, we did bring on a new provider, so that obviously did open up some of our access, but the blue line shows when we standardized their templates. And if you notice at the end, there's a little spike and then a little dip. That's actually because we realized there was an issue with how we had set them up, and we were able to correct within 2 weeks. So we're really hoping that the work we're doing is going to give us an accurate picture of where we actually are. So for the Women's Center, they were really focused on getting new OB patients in, and so they worked through a formula to be able to say, if we have this many births, we need to build in this many OB appointments. And so they're working through that piece of it, but we're really seeing that we're able to get our patients in faster.
That quote down there is very important because Debbie Stanley, being on the backside of a lot of this for her team, they can struggle with the templates. And so seeing some positive response from Debbie and her team means we're doing something right.
Well, and originally or previously, OB was one of the harder areas for them to schedule. And they have very simplified visit types. They have very specific ways of putting things in. The scheduling rules really make it a lot easier for them to be able to make sure they're doing it in the right place. And if you look at the two arrows, it's pretty small, but they did a provider and staff satisfaction survey. And in the beginning, the Access Center had said they had zero confidence that they were scheduling correctly. And in the second survey, we're seeing that they actually have, I think it was a 50% increase in satisfaction and confidence that they were scheduling correctly. So we're really excited about this. And the collaboration between the two groups in developing this was amazing to see. So it really is, it's not just about the OB providers having better templates. It's not just about the Access Center, but we're also seeing that we can get patients in. So it's a win-win-win. The other area that we're working with templates is primary care. And I'm not sure if any of you are aware, but we have many different providers with many different preferences. We have some providers who want to only see patients for 40 minutes, or some providers who only want to see, a certain amount of a certain visit type every day. If you look at the top picture, and you won't be able to see it, but it's a way to show that is how complicated our scheduling rules. Each of those columns is a provider. All of them have different timeframes around the different visit types. And to be honest with you, it's almost impossible to schedule accurately when there's that much complexity. But if you look at the bottom picture, these are our new rules. So there are one column, so all providers are following these same rules. We clarified our visit types and put really clear definitions around them, so there's no confusion about what's a follow-up visit versus an office visit established. And then we defined what should be a short or long visit. And all providers have agreed that they will focus, all primary care providers in Truckee, Tahoe City, and Incline will all be using this template.
How many providers is that? Nearly
16 in the MOB, 20 something?
Yeah, I would say we're in the 20s.
So I just want to underscore the significance of getting 20 providers to agree on a set of standards that are very simplified. That was no small feat, but this process really helped kind of facilitate that. And we have, I think right now, really good physician alignment around these new standards as a result, so.
We do. And potentially, just the changes that we've made in this first round of pieces could add up to 5,000 short visits a year. The other thing that this allows us to do is continue looking at some of the other complexities in primary care. So things like their panel sizes and acuity of who's seeing what. Right now, we're seeing a lot of variation in that. So we felt like this was the first building block of starting to do some of that more complicated work. We're also building a governance structure around how things change. Currently, there's a lot of variability, and providers are sort of able to just make decisions when they want to. And so that governance structure will allow us to keep things standard and to really have the medical teams be able to weigh into that. So we're excited about that.
So just quickly to add on the governance structure, this is where we invite them to the table to be part of that discussion. So we have a very successful governance structure here with the Perioperative Governance Committee. It meets routinely, and they talk through what, in their situation, is block time scheduling for the operating rooms. And initially, when it first started, there was a lot of hesitancy and kind of a feeling that they were losing some autonomy. I think now, as we really work with that group, I mean, they're the ones that are actually, they've defined what the guardrails are, and they in fact are working with other providers in either allowing additional block time for ORs, or potentially in some cases actually moving that time to other providers who potentially have been using the ORs and could use more time. So it's going amazingly well, and I feel like they have a seat at the table and they're really enjoying that conversation, and that's what we're looking to achieve here as well with this governance structure.
So we will open their templates for January 1. The reason for that delay is we already have patients scheduled out. So that we'll begin scheduling on the new templates January 1, and the first patient seen on that template will be March 1st. However, if there's a provider that has availability, we will follow the new rules, and are starting to look at that now for providers that do have availability. One of the things that's going to make this much better is that we're actually looking at primarily open templates, so any patient can go into the slots as long as there's the time limit available, with a few exceptions in around follow-up visits and hospital ER follow-ups. And then I'm going to pass it over to Jeff because he has primarily been working through behavioral health.
Yeah, so we're really pleased to have the opportunity to kind of expand some of our focus into the behavioral health area. I'm sure you guys are aware of the fact that that kicked off several months ago, and one of my colleagues, Stephanie Sargent, has been leading up that effort, working directly with your behavioral health leadership team, medical and operations leadership team. And so I know you heard from that group not too long ago, but just wanted to remind you that they have really robust roadmap to tackle some of the big issues. They've in the first quarter of working on the engagement, I think they tackled seven big initiatives, and I don't have an update for you on each of those initiatives, but I can tell you that they're all on track, on time, and progressing really well. So I think that group also has been really pleased with the work, and I've heard a lot of good feedback about their collaboration and alignment on the changes that they're seeking to make. So that work has just wrapped up. That engagement, the initial engagement, has just closed out, and there's consideration right now about additional visiting support for ongoing work, but we would say that was very successful and appreciate the opportunity to work with you guys on that. The other thing we wanted to talk a little bit about is the more recent work that we've kicked off around ortho scheduling and authorization work. This is, we may have mentioned this briefly already, but this is an effort to help improve the collaborative process of scheduling patients and getting authorizations between the Access Center and the ortho clinic. So that work is in its infancy, but as Kelly mentioned, we just wrapped up a 3-day event today where we facilitated the analysis of the current state and then the vision for future state. So we had 25 participants, and that was a cross-functional team made up of clinic resources and Access Center resources. And we worked through some really, really difficult issues. There's a long history of those two groups having a lot of, facing a lot of challenges and broken processes that have led to some resentment and, frankly, just some emotional and personal issues. But today, I feel like over the last 3 days, I feel like we actually broke through a lot of that, and we're able to, by mapping out the current state and all the underlying processes, we built a shared understanding of why we've struggled in the past, and we also built a foundation and a future state vision that will help us to break through those broken processes, replace those with ones that we believe will work. And I'm very confident that your patients are going to feel this, because there'll be a much more efficient and effective scheduling process. Your providers have will have fewer patients that they see in clinic, and then only later realize that the patient's not financially qualified to have their procedure done in the Tahoe Forest facilities. So that was a key pain point, and the team was able to address that as well. So we'll have more specific updates for you on that, but, and the only reason we don't tonight is because we just couldn't integrate all of the deliverables from the event into our presentation here, but I'm very optimistic, and I believe that you'll see some significant benefits out of that. We did have the report out where the executive leadership team participated. Dr. Dodd also came, and so the reaction or responses during the report out were favorable. So we're all hopeful and optimistic, and so over the next, I think over the next 90 days, there's a very robust implementation plan to bring that future state vision to life. So we'll have more on that. And I believe that was the last, yeah. All right, so happy to answer questions. I'm
I think we're all excited about this.
Yeah.
I can't even tell you how excited. I know we've had pediatrics, we've had behavioral health, and we've had the urgent care coming in, talking about how they've implemented some of the processes that you did. And it's just so rewarding to, number one, see them so engaged in their service line, making it the best they can make it.
Yes, ma'am.
And the huddles, I think, have really added to getting everybody engaged. So I'm excited to see how we keep it moving.
Yeah, absolutely.
How have the dyadic relationships tied in with the work that you're doing in management systems?
Oh, that's it's a really important part of it, a part of making it all happen. We are trying to actually leverage that dyadic relationship at the operations level. And so in cases where we're seeking to solve a specific problem, we always attempt to involve both members of that dyad in both defining the problem and determining who will be a part of developing the solutions. And so we've had, a great deal of success. Obviously, there've been, there's a lot of growth involved. It really is a culture change. So we have to recognize that, change in that arena doesn't always come quickly, doesn't always come overnight. But I do think I could, provide you some specific examples of where the application of some of the management system tools have actually facilitated the development or growth of those healthy dyadic relationships. Yeah.
I think I'd like to add, around the template work, it really has been both the operational and medical director who are defining those. And it's been a partnership the entire time, and I think that's really strengthened that relationship and kind of defined it a little bit better.
There are other examples. So, the example that Kelly shared with you where we had a concern surfaced by a provider, and we took the time to study the problem, only to realize that the problem wasn't as big as we thought when we looked at the data, and we decided to focus elsewhere. I think that was it was certainly the operations leadership team, but I think the medical leadership team was involved in that. So by using that problem-solving process, we're able to gain alignment. And I would not want to speak on behalf of the physician who brought up the concern, but I did hear that we achieved what we set out to do, which was understand the problem and determine if it was a big problem, growing problem, or if it was a small problem. And that provider was involved all along the way and came to the same conclusion. So it was a partnership or dyadic agreement. What Kelly shared with you was, I think, the result of applying the tools to manage those relationships.
So what I'm hearing, and because we've had the issue of whether or not physicians felt they were being heard, in this particular example, what I'm hearing is that the physician had a concern. You analyzed the concern to the point where he was satisfied
Yes.
that it had been thoroughly explored, and the solutions to either do something or not do something were the end result of his feeling like he'd been listened to and got a solution. So I just have to say, I think the more that happens,
Yes.
the better we're going to have alignment top to bottom.
Yeah.
Well, and we did that with data. So as we started off this, a lot of the old way we would do things is we kind of react emotionally, right? And so I think when you're able to stop, pause, figure out what the problem actually is, and then support the answer with data, then there's a lot more clarity for everybody to understand whether or not we have a problem. And of course, if there was a problem, then we would have the data as that foundational block to kind of move us to that next step. So, not only are we working with, many stakeholders, not just providers, but many stakeholders in terms of, making sure they're heard, but when they bring up a problem, we can first examine if the problem really requires the amount of resources that we would potentially have to put into it. So I think it's a great path forward in terms of just changing the way we make decisions.
So speaking of data, I remember over a year ago, we were presented with a report, primary care physicians, huge range of productivity. Has any of that changed as a result of your work?
I'd say we're not seeing many of those changes yet, but the work we're doing around the templates will even that out. So for example, a provider who's only seeing 40-minute patient or 40-minute visits is obviously going to have less patients a day. When they move to the new structure where that provider will be required to see patients in 20-minute visits for certain visit types, we expect that that will increase. And we expect that as we sort of standardize across the board, that we should see some more leveling out.
Yeah.
How easy is it to collect the data that you're looking at?
It's not as easy as we would like. You guys have heard about the challenges over the years. But like I said earlier, I do think us making these changes, so a good example, slot utilization. We want to understand how many slots are being filled a day. Currently, the way that the templates were being built, certain slots weren't showing up actually on that report, so a provider could never get to 100% because they were not, like their lunches were showing as they were available. We're fixing those kinds of things on the back end, which should make that more accurate and easier to get, so we won't have to do as much grouping or, I hesitate to say manipulation, but we won't have to play with the data in order to have it make sense, because what we're getting out of Epic will make sense or more sense.
I remind you of the slide that Kelly shared that showed the equivalent of 5,000 incremental visits, the potential for that. And that comes from converting a lot of longer 40-minute appointments to 20-minute appointments. And so while I can't tell you exactly what that'll equate to, that's all productivity. That's not an investment in more providers or, expanding available windows. It's better utilization of the existing time. So you would expect, and I think it's reasonable to think that that 5,000 or so incremental visit capacity will be filled with patients that are now currently waiting. And so that really represents nearly a 20% increase over the number of visits that you had in the previous 12-month window. So it won't translate exactly to a 20 or 25% increase in productivity, because those will be shorter appointments, likely shorter appointments, and not at the billable rates won't be quite as high. So when we look at the RVUs, you won't necessarily see a 20 to 25% bump, but certainly we're unlocking the opportunity for a good sizable increase.
So in the grocery store line, in years past, I would frequently get people who know me, know I'm on the board. I tried to get an appointment and I'm 6 months out. I know that's anecdotal, but is there any solid information about, for instance, a primary care appointment, time wait being lessened? And if so, do you have any idea of what the numbers are?
So we can actually go back to the slide on the third next available. So the third next available is the standard measure that we use in healthcare to say how long out to an appointment, because the first one could be a cancellation, the second one could be another cancellation, the third typically is what's actually available. So this is really a report that should tell us how many days are out. Right now, we know that there's still some flaws in the data, and we know that we're still making those improvements, and in January, we should be able to see for primary care what's more accurate. And then as we continue to open the templates, we should be able to see that. And these would be the numbers that you're looking at. So currently, I think that's very small.
We're not quite good enough to read
No,
that. So.
we're not. Yeah, we're not close to where we need to be. Yeah, but we do think that we're making incremental progress towards that.
What is the number?
I believe it's around 35 as an average across.
From here, it looks about 35 days. So.
And this data particularly includes primary care, pediatrics, OB, and all of our primary care. So it's an aggregate. But we do have reporting that would for each of those.
So is that defined as a patient calls in to seek a kind of a regular appointment as opposed to a special needs appointment? And they get in 35 days?
So this this chart actually shows you for an established patient. So if we're looking at established patients, that would be an office visit established, a physical, annual Medicare visit. So there's a grouping of them that would be those visits. And then we have new visit, we're also tracking the new visits. We are looking at, as part of this, particularly looking at it by visit type rather than by provider by visit type, and that will tell us, do we have enough follow-up appointments? Do we have enough new patient appointments? And so when we get to a point where we can feel like we trust the data more, we should be able to look at all of those things and make operational decisions around them. But does that answer your question?
Yeah, let me just follow that up by saying, you're having to project into the future what the categories of appointments are. And so to have the spaces for those, you have to know how many are going to fit each category. And I guess you're working on the data to get that, is that right?
Yes. So we tried to do some analysis previously and have some sort of projections, I guess, not specifically on, but we have like trends that we're looking at. But because the data has been so skewed, we've had people using various visit types differently. So it's been really hard to actually get that information. By standardizing the visit types and having the access center as well as the providers and the scheduling, all using the same things, we should be able to better predict what we actually need and look at trends over time. We do think that it will vastly improve our ability to make operational decisions around that.
How long do you think it'll take you to get to that point?
So I will say OB is already starting to get to that point, or at least being able to look at it. Their problem that they were really looking at was not being able to get new OB patients in. So, and for an OB patient, you have a suite of visits over the course of the pregnancy, and they've started to look at how we can quantify that and make sure that we have enough visits for them, and then flex it so that you still have your GYN visits as well. So I wouldn't say we're very far or sophisticated in that yet, but I do think it's forward progress.
I think one thing you can look forward to is in March, when the new templates are fully in place and patients have been scheduled with the new templates that are completely standardized, one of the mechanisms we'll put in place is a tracking metric to ensure that we're not underutilizing certain visit types. And if we see that that's the case, then that's our indicator that we might need to adjust down the number of that particular visit type on the templates going forward. So that's our first sort of leading visibility into whether or not we've gotten it right. So we have to take the data that Kelly mentioned that's maybe not as clean as we would like it to be, make some projections, build our templates around that data, and then begin to immediately track the utilization going forward to see where we need to make adjustments.
Well, it sounds like you're clearing some of the cobwebs from.
That's a great metaphor. Yeah, love it. Yeah.
I have a question, if I may, and this, thank you so much for the presentation. This is wonderful. Everything that Vivian has touched has been kind of magical. But I'm going to be the devil's advocate here for a minute. And I'm wondering if there is such a thing as too much standardization, especially in healthcare. I mean, we can't schedule when people are going to get sick and how acute that's going to be and what have you.
Sure.
So I'm wondering if there's enough variation in here that it will accommodate those kinds of things, but also that it doesn't wash culture. It doesn't wash away everything so that we become vanilla in our approach. And it concerns me as I'm listening to this, that I want to know that we won't lose the culture and that we will have variation.
I can speak specifically to primary care because I think that is a concern of the providers as well. We haven't built their templates so strictly that they don't have any variation. We are actually allowing them, some providers only want to see 4 new patients a day, some would like to see 6. We're saying the minimum that you need to see is 4, or we're building in rules so that we can do that, but if they want to see more, they can. Another example is Dr. Barta. Gina Barta currently works on 1530s, so she sees patients in 20-minute appointments and 30-minute appointments. Almost all of our other primary care providers prefer 20/40, so we're allowing them to keep that. And so I think we're trying to balance that right now and really looking at, and it's also part of why we're kind of taking incremental steps towards things. We don't want to be so prescriptive that they're changing their way of practicing medicine, but we also need to have it a little bit more structured so that it isn't terrible for the Access Center to be able to schedule, or so that we aren't limiting our patient availability so much that we have these giant wait lists. So I do think we're trying to strike that balance. And I would add that the way we got to the standard visit types was by having 5 or 6 of our providers actually be part of a rapid improvement event where they made the decisions around which visit types we were going to do. They helped write the definitions. They actually were the ones who said, we think this visit needs to be a 20-minute or a short visit. This one needs to be a long. And there was a lot of back and forth in that. So we're really trying to make sure that their voices are heard, and we're giving them some flexibility to still practice medicine the way they want to, but also building something that's sustainable and easier to manage.
You know, I think one of the most powerful things in the past year and a half that we've been working on this is, it was interesting because we oftentimes talk about the provider's voice, and of course, very, very important to hear from the providers. But when the providers and the Access Center came together in the same room, and they had this discussion about the templates, it was amazing to see the providers respond to the Access Center employees, and they had no idea the challenges that the Access Center employees were dealing with in terms of scheduling patients. So I think that there was a lot of opportunities for just quick change. And I just want to touch on, Mary, the comment about culture is so important to us, being in a community health system, that we want to, really fiercely protect that. And I think that when we think about how everyone can be involved in that, it's through the use of that governance structure, right? So I think that governance committee is going to be really important as we move forward in terms of making sure that we get all viewpoints as we kind of create a better path forward for patients to get access to the health system, because that's really been the biggest challenge, surely in the time that I've been here. And so we're responding to that challenge, and I think we're doing it in a way that's very collaborative.
Along those lines, what does the Access Center say to a patient who calls and says, I really need to see my doctor? Well, I'm sorry, we don't have anything open. You can go to urgent care. No, I've been to my doctor for 3 times on this thing. I want to see my doctor again, and I need to see him soon. What does our culture allow?
That may not be a question for them. Of course, we try to meet the needs of the patients, of course, but, we have schedules, right? And so I'd assume that maybe their doctor is with other patients that feel like they're with their doctor. And so there are times that we can't always accommodate that day, but we do absolutely have sometimes blocked slots available, so that if somebody calls in the morning, I know in pediatrics, for example, we keep 17 slots, I believe, where patients can call in the morning and they can come in and they can be seen by a provider. Sometimes it's not always their doctor, but it's their clinic. Their doctor's surely part of that care, and it's a little bit more familiar to them than urgent care or surely the ER, right? But we try to accommodate as much as we can, but there have been times, surely, where people have been told maybe they have to wait till the next day, or maybe their need is urgent care that day. But we're working on it.
Go ahead, Kelly. There's also a wait list process that the Access Center uses where, they'll recognize the needs of the patient, but know that they can't get them in today or, really short term. So they offer that option to the patient to be placed on the wait list. And if there's a change in the schedule, then that patient gets, preferred, opportunity for that newly available window or newly available slot. You asked for anecdotal stories earlier, and there is an anecdotal story around that. One of the Tahoe Forest employees, who's not directly related in this work but is aware of everything that's going on, shared with us a story recently of one of her neighbors in the community who complimented the fact that she was placed on the wait list, but very quickly was placed into an available slot when it came open, and observed that as a change. Now, it's anecdotal, so I don't want to portray it as typical or normal, but I do want to just share that with you because that process is something of a satisfier for patients who are otherwise dissatisfied that they can't get in.
I would add that as part of the primary care work that we're doing, standardizing their templates, there was a lot of energy around ensuring that providers could get in urgent patients or urgent follow-ups. And so what we've done is we've done 2 blocks per provider for being able to get follow-up patients. Those will be released. I believe it's 48 hours, but I believe it's 48 hours.
Yeah, but it's not 3 weeks.
But it's not 3 weeks. And so it really does allow the providers to make some decisions around if Dale really needs to come in for a follow-up because of the visit we had today, that they can get them in.
And I probably will.
Yeah, so great work. I think where this is all going again, you know, it's this mix of standardization and ensuring that there's a collaborative effort here. But I think some of the tools that I'm really excited about that, you know, is kind of on the back end of this work is the ability for patients to self-schedule. I think that that's going to be transformative for this community. And I also think that the use of Fast Track, which ultimately allows in a situation where maybe there's a cancellation, you know, somebody isn't able to make it tomorrow, they cancel with us, then it automatically will send out text notifications to patients that are in need of that same type of visit, right? So it will speed up that process quite a bit, and I think people will see, you know, a marked change in access to care once all of this comes to fruition.
I would like to acknowledge and appreciate your comment, Mary, about the work that Vizient's doing, and you kind of tagged it as the Vizient work. But I also want to, in the same breath, make sure that you guys know that we're undertaking a deliberate strategic effort to ensure that this is not perceived within the hospital as a Vizient short-term, you know, engagement type work. This is truly culture change, and the tools that we're trying to help, you know, propagate through the system are really the Tahoe Forest tools and the Tahoe Forest way, and we'll put some branding around that, but we want to make sure that this is not perceived as a, you know, a Vizient engagement. And in fact, I just want to emphasize again, a lot of the work that you see reflected here is the product of, you know, Kelly's leadership, the leadership of, you know, the departmental leaders, and it's really satisfying for me to be able to tell you that this is really beginning to be the way things get done. And I know that because when I'm working with leaders on the work that we're specifically involved in, they're also sharing with me about stories about how they've used the tools successfully in other endeavors. So I really appreciate that.
We actually had that discussion just earlier this week.
Oh, yeah? Okay, good.
But thank you for reminding us.
Yeah.
Any more comments? Kelly, any additional things that you want to enlighten us on?
No, I don't think so.
That's okay. You've done a great job.
Thank
What
you.
you've told us, we really appreciate all the details too of how we came to where we are right now. So thank you for that, and of course Jeff leading us. And we'll have to think of maybe renaming the Vizient project.
For the next update, yeah.
Yeah, the Truckee Way or the Tahoe Way or the Hospital Way.
Well, whatever we end up calling it, I'm just glad to be a part of it. So I appreciate
And
the opportunity.
we
to
are
work
very
with you
happy
guys,
to have
so
you
it's
here.
great.
Any comments from our audience on the project?
Covered it.
Yeah. Well, thank you so much, and we look forward to hearing from you again at some point.
Thank you.
Appreciate it.
Good job.
And now we'll go to our next item agenda, which is our 5-star rating that Janet and Heather Hiller is going to present.
Good evening. Can you hear me okay?
Yeah. Can you tell us a little bit about yourself? I don't think
Yes,
I...
no problem. Can you hear me now?
Yeah.
Well, thank you for having me. My name is Heather Hiller, and I work in quality. I'm a nurse by background, but I'm a clinical analyst for quality, and I do a lot of the core measure data reporting. Speaking of data, there was a lot of talk with data. So I was like, oh, that's my term there. So I'm going to do just
I
a,
introduce.
Oh,
And I'm
yes.
Jana Van Gilde, the Director of Quality and Regulations, but I really wanted to make sure our Quality Medical Director, Dr. Conway, came over from Incline to join us and answer any questions. And then Dr. Brian Evans, who's our Chief Medical Officer, both of them have been very much involved in this process, along with the medical staff, clinical staff, et cetera.
So I'm just going to do a brief, I know you've had a long day, so I'm going to keep mine short and sweet, but some digestible education on the star rating and what that's all about. So what is a star rating? The CMS, I think a lot of us know what this is already, but here's just a little blurb from the internet of what it's a rating system that shows quality of health and drug services. And you can see there that there's a range from 1 to 5 stars. And this is where the consumer can go on to what's called Care Compare website, and they can search by zip code or town or specific hospital and just look at the star ratings. And so I have here just some screenshots of what Tahoe Forest and Incline, a patient would see on this website. And then the last rating that we had, I'm going to go over that in the next slide of when we had a last rating and what that all entails to get a star rating. And so what is needed to receive a quality star rating? So hospitals have to meet the minimum reporting requirements. So that means 3 measure groups with 3 measures in each of those groups. And one of them has to be mortality or safety of care. And I'll show you a visual of kind of what that looks like. The hospital measure group score is calculated from individual scores and then individual measure weights. And so if you don't meet the threshold for the minimum reporting, you don't get a star rating. And our last quality rating was in July of 2023, and we were at 3 stars. So I won't try to explain all this to you because, as you guys know, CMS likes to keep things really simple. And this is just an algorithm of how the star ratings are calculated. It's newish. When did they come out? In 2021 with?
They revised it in January of 2021.
Yeah. So you have these measure groups, and then you get a hospital summary score, and then you are benchmarked against your peers. So either you're set up, you're scored against hospitals who have 5 measure groups, 4 measure groups, or 3 measure groups. And this is a little busy also, but this is just going to break down the different groups, and this shows you what measures within each group. So across the top, we have timely and effective care, readmission, patient experience, mortality, and safety of care. And so those 2 on the right, those are the 2 that you have to have 3 measures to actually get a star rating. So I put in yellow the measures that we did not have enough data to get that measure included. So that's why last year when they published the star ratings, we did not get one. I put a little information on here of, what sorts of data, where does the data come from? It's a variety of sources. There's claims data. There are patient satisfaction survey data from HCAHPS or Press Ganey, and then there's some manual submissions that we submit to CMS. Out of 40, I think it's hard to see because it's small. I think it's 47 measures total possible that a hospital can be scored on. We are a small hospital, so we have enough data for 28 to 30 measures to get counted into that. So here's just some of our top measures. Don't try to pay too much attention to the IDs or the acronyms, but I think what's important to know with the CMS data is it's pretty delayed. When they publish publicly reported data is almost 2 years behind. So this is the most recent release, and the most recent data was through March of 2023. So summary on the star rating, we perform well on all patient experience measures, as you saw in that slide. We are a 5-star rated on that patient experience. Other ones we do well on sepsis, ED measures, and C. diff. There are some improvement efforts that are going on with the star rating improvement team, and that is looking at readmissions, total joint complications, ED visits after chemo, some imaging measures, and There's some measures that we've done some deep dives that we don't have a lot of control over, especially since we have such low numbers, like our N is so low, so it doesn't take a lot to throw us, as an outlier. We're looking into some Mercy Epic issues in coding that also is impacting some of these quality measures. And there's been a lot of work done on readmissions and complications, surgical outcomes. We have a transitional care management program, and then the last couple of years, the pre-op clinic, and that process of optimizing patients for surgery has been a lot of work on that. So we're hoping as the data becomes more current, we will see all of that great work reflected. All right, so now we're just going to keep on the topic of standard work. So this is a very common theme these days. We're trying to really get staff used to this term of standard work. So we put together bundles per Dr. Evans' request to track some of these measures and do the bundles, and also to report out on how we're doing that. So processes, we're standardizing it, and then we're looking at the outcomes. All of these, except for falls, will impact the star rating measures. So here's an example of one that we have, Kelly Bottomley in the Cancer Center has done a lot of work with. This is a measure that is in our star rating. It's ED visits after chemotherapy, the bundle of what they're doing for each new chemo patient, and the goal is to prevent them from coming to the ER. And so on the left, you can see the compliance with the bundle January through August. And then as you can see on the right, the outcome, the intention is for this to see that going down, and it's working. Same for surgical site infections. So this is a SSI bundle. Svieta has done a ton of work with our operative group of our staff, the OR, and they have been tracking what's best practice to prevent an SSI. And on the left, I have both of them there together. So the SSI bundle, the line is on the top, and as you can see, the outcome of number of SSIs is going in the right direction. We only have through Q3 so far, but on the right, you can see the trend from 2021 through year to date, the work that has improved on our decreasing our SSIs. And what is our goal? 5 stars, and I think that's our 5-year goal, Dr. Evans, right? We want to be 5 stars in 5 years from now?
No.
Or as soon as possible.
Preferably 5 days.
Yeah. Yes, I think we can get there.
But it may take that because of the background, the historical data that they're using, right? So we might be there today, we just don't know it yet.
Yeah, totally.
Yes.
Have we ever been a 5-star?
Oh, yeah.
We were 4 stars.
Yeah.
4?
And then in January, we were consistently 4-star, and then in January of 2021, like Heather said, they changed the way they calculated the star rating across the country, and then we dropped to 2, and then we went back up to 3. And like I said, we are doing better. I really do believe that, based on these standard work bundles and the data we're collecting, but we won't see that for probably another 2 years, just because of the way the data.
And did the standard work bundles come from a resource, or did we look at our practice?
A little bit of both. Like there's best practice, like for sepsis, there's the sepsis 3 and 6 hour bundles.
Right.
Which is standard of care that CMS expects all hospitals to comply with. So we do have that as our sepsis bundle. And then some of the other ones, there's a mix of, like, say, falls is just what are we doing to prevent patients from falling in our organization, and making sure that's done every time. So there's benchmarking with best practices, but there's also like internal decision of what that looks like.
Okay.
If a patient is looking for a procedure and is vetting certain hospitals, including us, but options are Renown or Barton or some of the others, are they 5-star rated?
No.
They're not?
They're 2 or 3.
2 or 3?
Barton was 5 stars about 4 years ago, 5 years ago, pre-COVID, but they have dropped off since then with some changes. So, no.
Okay.
Well, the other interesting part about the 5 stars is you have to have patients, and you have to be able to track a lot of these items. And there might be hospitals that are small that give excellent care and have good outcomes, but they can't get the 5 stars or even a 3-star because they don't have the numbers.
Right. And if that graph with the categories in each measure, we are a small hospital and we have enough data for 27 out of 47 measures. And then we are benchmarked against all hospitals if we fall into that 5-measure group section. So it puts us at a disadvantage.
Any other comments about the 5 stars from our audience? I mean, from our board before I go to our audience?
No, nice work. It's tough to get there, but you're on the job.
And it's made a difference with the bundles too, I think. Yep. Anything from our audience about our 5 stars?
Good job.
Yeah, absolutely.
Really great job.
I remember when we first started talking about this, and it was, I think that the whole idea, rather than measuring the outcome, we measure the process.
Yeah.
Yep.
It gets us there, and if we measure that right thing, then the outcome will follow.
And you saw the.
And you can just see it so well evidenced there. Yeah.
There's been some shift in thinking, especially with the inpatient nursing staff, of thinking of like, why are we tracking these things? And so just trying to get them used to that, that process that we're looking to prevent a fallout instead of reporting on when we did have a fallout.
And then looking back to see how we could prevent the fallout.
More proactive, not retroactive.
Okay.
Yeah, I know this evening we're looking at the hospital star rating, but every chance we get, we like to celebrate our ECC, our extended care facility. They are a 5-star facility, and that is amazingly hard to do. And so just every chance we get, we like to call out our ECC as a 5-star facility. It's pretty awesome.
And we have been consistently, as the group said, 5 stars for our HCAHPS, our inpatient rating. So, and you saw that in the graph, that has been consistently 5 stars for a couple of years, for many years. So, but it's the quality of care that we're focused on, because they changed the calculation.
Well, thank you guys again for your presentation, and we look forward to continue work on getting us to that 5-star rating.
We'll have a party.
Yeah, well, we definitely will celebrate that one, won't we? All right, so 15, we did not pull anything from our consent calendar. 16 is our board committee reports. The Executive Comp Committee met.
Yes, the Executive Comp Committee met, I want to say sometime around the beginning of the month. And what we wanted to do is, as everybody knows, we're going through this executive search process, and we wanted to have a salary range that we had validated more recently to know what we're going to be looking at moving forward. So we met once, we looked at it, we tweaked it a little bit. Alex took it back to Alliant, not Future Sense no longer. And so we tweaked that number a little bit, and we've come out with a range in salary offerings that we think will be competitive and will be good. So that was our charge, and that's what we did. So.
Thank you, Mary. Any reports from our foundation boards?
Yes, last night before last, we had a wonderful party.
The night before.
Hosted by Julie Teal, who was a member of the Incline Village Foundation Hospital Board. She and her husband own Rayleigh's. For the last several years, they've hosted a party at the new Rayleigh's there by the airport. It's a great affair. And a lot of things to celebrate with the Incline Village Foundation. They're doing quite well.
Go ahead. It's great to see the 3 different boards come together, and just that collegiality and discussions it's the one night a year we actually get to do that, so it's a great event.
And then the Truckee Foundation meeting was canceled last minute due to the inavailability of some data that we needed for the meeting, so no report there.
Okay. Just a reminder that our next board meeting in December is the third Thursday because of the holiday, and so we don't want anybody to miss our meeting, so that's why I'm announcing it. We have nothing for the closed session, so if there's no further remarks from our board, I am going to adjourn the meeting.
I'm just going to say one remark, which is I may not be able to serve in the future. I just want to say we've got two great board members, a new one that's coming on, and Alice will be with you. I want to tell you how much I love this organization and love the people in this room, and I want to thank you for giving me the opportunity to serve and appreciate the great work that you do.
And
Thank you.
we are inviting you back for the meeting in December.
I'll come.
All right, then the meeting is adjourned.